of all, for the audience, I'll just introduce myself. My name is Dr. Tarun Grover. I am the Director for Vascular and Endovascular Sciences at Medanta, the Medicity Hospital. And I've been working there for last 15 years.
This is the first episode and we are starting about deep diving into challenges and innovations in wound care, specifically difficult to heal wounds or hard to heal wounds. And today we will deep dive into diabetic foot and the challenges for that.
For inviting me over and giving me this opportunity to share my experience in dealing with diabetic foot ulcers. And I would say and congratulate that it's a very good initiative. Say that when I was getting trained as a general surgeon, my interest towards vascular surgery developed because today also if you talk to any general surgeon, I think the most fearsome part for their procedures is to having an uncontrolled bleeding, or mostly the general surgeon, they feel very scared of blood vessels. So this was, I would say, the encouraging bit for me, because I used to feel that, why we should feel scared of blood vessels. We should deal with them and we can easily handle them. When people used to talk about vascular surgery, they used to think that vascular surgery means only varicose veins or Berger's disease or an amputation. That's all. And there were hardly any procedures done during that time. And so we had to really work hard. And this was something because it was too mystical and mysterious branch. And there were very few training centers. But I was lucky to get an opportunity to get trained in vascular, and then eventually become a vascular surgeon. And I'm very proud to say that now we almost are doing every possible procedure which is done anywhere else in the world. Now it's being done in India as well in vascular surgery.
And thank you. I think this is incredible. You have been the pioneer in the vascular surgery department, and generally what changes you have seen in last 5-10 years in vascular surgery as a
I think the most challenging bit in the beginning was bringing awareness. I'll just give you one anecdote that my parents are also, now they're retired, they are doctors, but they had almost practiced for almost 60 years. And I think even post 10 to 15 years, my career in vascular surgery, they themselves being physicians, they used to still always ask me, what do you do? Like, what is vascular surgery? So I would say the major hurdle was awareness, not among the general public, but even among the physicians. But the change which has come in last a decade or so is that at least now people are aware that there is a specialty by the name of vascular surgery, which means that this specialty deals with all the blood vessels in your body except heart. So any blood vessel which is either blocked or it gets injured or it gets diseased, so that is handled by us, whether these vessels are supplying any organ, whether they are supplying any limb, or they're supplying our brain. So I would say apart from the advancement in techniques, the awareness is the one which I would say is something which we are really seeing the difference now.
So, and as a physician, as a trained physician, for me also it took some time to understand what is vascular and what is CTVS.
Yeah.
How do you differentiate these two?
So, it's a very interesting question because, it's a sub-branch from the cardiothoracic and vascular specialty, because initially it used to be called CTVS. And so since the cardiac surgeons were getting busier and busier with cardiac surgeries, so vascular was something which was getting neglected. Some people by choice opted for thoracic as well. Thoracic means when they are dealing with surgery operating on the lungs. So vascular was something which was getting neglected by the surgeons who were operating on the lungs, surgeons who were operating on the heart. So then there were a few people who, and in the Western world, especially in the UK and the US, vascular was an independent specialty from a very long time. So a lot of people who were trained abroad, they realized that there is significant, I would say, vacuum in India, a space which needs to be filled. And so some like-minded people, they started training centers and they started convincing the Department of Health in India, the Ministry of Health and Family Welfare, to initiate programs in vascular surgery. So 2001 was the first training program, a recognized training program by the Diplomate of National Board was initiated in India. And before that, there were no training programs. So,
very interesting.
And since then, now we almost have 40-45 training centers in India, which are training vascular surgeons or people who are getting trained in vascular surgery.
And sir, just to follow up on this, and for the residents, medical students who are listening to this podcast, so for cardiac surgeons, so for example, the leading process is the bypass surgery they deal with. Cardiologists, the angioplasty or MI. For vascular surgeons, what are 2-3 top procedures which you deal with?
So, whenever we try to address general public or somebody who does not have a medical background, a very good analogy to explain them that what we do is that everybody is aware of heart attack.
Yeah.
So we tell them that it is not that you can get a heart attack only in your heart. You can get a heart attack of your legs. You can get heart attack of your brain also. Which means that if the blood vessel or the blood supply which is going to your legs gets blocked, so there would be pain in your legs while walking because of mismatch between demand and supply. So we call it a leg attack of the heart attack or leg attack. Similarly, if the blood supply which is going to your brain, it gets blocked, so you can have a paralytic attack or a stroke. So we call it a brain attack. So mostly I would say vascular surgeons, the 70 to 80% of their practice is, we call it revascularization, which means the blood vessel which have got blocked in the legs. So what we do is we either do bypasses for them or we open them with stents, similarly as you open the blood vessel in the heart. But here there are a lot of new techniques which have come up in last, I would say 10 to 15 years. Like you have got special drilling machine which are called atherectomy devices, or there are laser atherectomies, and there are special equipment which can remove clots from your legs, especially without making long incisions or without making any cuts or doing any bypasses.
Got it. So now coming to diabetes, India is a diabetic capital of the world. India has a large burden of diabetes. And one of the common conditions we see is diabetic foot. How do you see that as a problem for Indians? Diabetes as a problem and diabetic foot as a problem?
Recently I'll narrate an incident that, we were in one of the meetings and one of the physician was mentioning that, we are almost heading towards a silent epidemic. So I would say it's no more silent now. It's become very loud and clear that India has become the diabetic capital of the world. We have got the largest number of diabetics in India, and you can imagine even the number of pre-diabetics in India, which is a very large number. Now, these diabetic patients, I would say, the international data suggests that 15 to 20% of diabetic patients would definitely develop some foot complication in their lifespan.
Okay.
Which almost doubles in Indian subset of population because of the poor hygiene, people walking barefoot, socioeconomic status, and sometimes adapting to, I would say, alternative medical therapies as well. And these days, what we are seeing is that I would say every outpatient or in our OPD, every day we see 15 to 20 new patients with diabetic foot complication. We have a very busy diabetic foot care clinic at our institute. And the main reason to initiate that foot care clinic was to educate and bring awareness in the diabetic patients so that they could invest in prevention. But the problem is that we get patients who come to us very late, because they don't realize that what is the importance of prevention in these diabetic subset of patients. Multifactorial in these patients. Number one, they have insensate feet, which means because of significant neuropathy, they don't feel the sensation of pain, perception of cold or hot. Insensate feet, so they are subjected to extrinsic injury. Once they develop an extrinsic injury, because of poor blood supply, because of uncontrolled sugar, the infection sets in, and then these wound infections, they complicate so fast. And if you compare with a person who is non-diabetic, you can still cure these ulcers or wounds, but they definitely tend to misbehave and be very aggressive in diabetic patients.
And do you see a demographic divide in the patients you see in your diabetic foot clinic, male versus females, old age versus or some village or urban, some demographic?
I would say a lot of people, they have this misconception that probably diabetic foot complication is a pathology or a disease which only happens with people who are of a poor socioeconomic status. It doesn't happen with people who are more aware, or they are socioeconomically, they are better placed. But I would say that's a misconception, because apart from little more preponderance towards male patient, I would say, because probably they are little more working in the outer settings, and the chances of injuring their feet or getting exposed to more trauma is little extra. But apart from that, I would say the diabetic foot infection is equally prone in all socioeconomic status.
You mentioned 40% of the diabetic patient would have some kind of foot complication, and how much of them would undergo amputation to a serious, which is a serious.
So it keeps on multiplying. That when we see and when we talk about complications of diabetic foot in diabetic patients, what we are seeing is that out of these patients who develop diabetic foot ulcers, good 10 to 20% of patients would require some form of an amputation. And though that's not a good thing, but I would, for the interest of the audience or the listeners, I would say that sometimes we should not look towards amputation as a failure of treatment also, because sometimes people, when they come to us, suppose the toe is very badly infected, which requires an amputation, and sometimes they shy away from the amputation, and people don't convince them seriously about the consequence if they don't go for an amputation, because having a smaller amputation and salvaging a major part of the limb is very important. You can imagine if somebody lands up with a 4-foot infection and we do a 4-foot amputation, at least patient will have his hind foot and they can walk on it. But if we neglect that and the patient lands up with a below knee or an above knee amputation, in that case, the morbidity and the eventual complications are more. And it doesn't stop there. There is enough data to show that diabetic patients who land up with an amputation for a diabetic foot complication, 30% of them would die within next 5 years. So you can imagine that it's just not the amputation, their overall survival also gets affected. And there are a lot of studies where they have compared the survival of a post diabetic foot amputation to major malignancies also, something like a colon cancer or a lung cancer. Patients with a diabetic foot amputation have a higher mortality rate than these cancers conditions also. So that's something.
And you mentioned that a lot of people end up late in your center, and what's the reason for that? They keep managing and they don't go to a proper wound specialist.
So first of all, I would say that it's a very aggressive disease. Diabetic foot infection, a lot of times people are not lying when they tell us that it happened within 48 hours, within 24 hours.
Oh,
it does happens also, because the immunity is low because of high sugar, there is lead blood supply, and because of injudicious use of antibiotics, the bugs in our community have become resistant to antibiotics, and they become very aggressive also, the bacteria. So the infection becomes very aggressive. So number one, the aggressiveness of disease is very high. Number two, definitely what we have discussed before, that people try to use some alternative therapies, some local ointments, or I would say some chemicals, whatever they have heard about using on their feet. And so there is a unmet need for proper diabetic foot care specialist, proper wound care clinics who can identify these patients, who can counsel these patients and provide them proper care for their diabetic foot infections.
How do you approach these patients when they come to your clinic? What is the treatment approach? What is the pathogenesis, and how do you manage that?
So we have to look at these patients holistically. It's just not that we are dealing with the foot care infection, because these patients, they require proper counseling. and we need to take care of their blood sugars, because here what we are dealing with a complication of a disease. So we need to take care of the disease per se, which is very important. Then we have to assess their vascularity, which is very important, where our role as a vascular surgeon comes in, because if we don't increase the blood supply, whatever we do, whatever newer ointments or newer dressings, newer medicines we use, but if there is no significant blood reaching the tissues, it's something like I always tell my patient that, you might have a fancy car, but if there is no gas, there is no petrol, you can't drive it anywhere.
Yeah.
So similarly, if you have a wound on your leg and there is no blood supply, no matter what you do, it is not going to heal. So it's very important to bring blood to the wound. So that's where our role comes in. Simultaneously, these people, they require some psychological support also, because in case we need to go ahead with some sort of an amputation, then they have to be mentally prepared, because we have to keep their morale high. We have to rehabilitate them. A lot of patients would be suffering from concomitant disease also. Vascular disease is a systemic disease. It's not that it will only affect their legs, or somebody who has a coronary artery blockage in their heart, he will not have blockages in their leg. So simultaneously, we have to look for other systems as well. A lot of these diabetic patients, they have chronic kidney disease also, which further compromises their recovery from infection. And one most important part, which usually people neglect when they're dealing with diabetic foot infection, is nutrition, which also plays a very important role, because unless until somebody is given a proper nutrition, proper minerals, proper vitamins, these wounds are not going to heal.
So you said first assess the vascularity, assess the comorbidities, assess the nutritional status, and most importantly, control the disease per se. And once that is being done, how do you stage it, and what management comes in?
What we need to do with the wound is that in diabetic foot infections, we have to be a little aggressive. So, if we feel that there is, say, some tissues which needs to be debrided or which needs to be removed from the wound, I would say be aggressive. You can remove 10% extra, because you will never get disappointed with that, because more aggressive you are in removing the dead and slough from the wound, the better the result would be, because all these infection happens because of the bacteria colonizing these dead tissue. So if there is no dead slough or dead tissue in the wound, the chances of getting a better cure from the infection becomes high. So good debridement is very important, and simultaneously you need to take care of the vascularity. And at some stage, now we can opt for newer treatment options also, which are available in the market now.
And so you mentioned debridement, and after the debridement is done, the wound needs to be prepared for granulation. What is the role of advanced negative pressure wound therapy in diabetic foot
I would
ulcers?
say that as something which has really revolutionized the treatment for especially diabetic foot infection, and apart from diabetic, other wound infections also, for for general surgery, people who have abdominal wound, or cardiac surgeons when they used to have a chest dehiscence because of infection. So mostly, these were wounds which were significantly exudative, which means they had a lot of exudates or serous fluid coming out from the wound. And it was very difficult to manage with daily dressing, because if you see the scenario in our country, people, they need to travel to a hospital to get their dressings done, or they might call somebody at their home to do a dressing, but still getting dressing done twice or thrice daily is a big challenge because of logistics, distances, finances, everything. And if the wound stays wet, it's not going to heal, it will macerate. So what negative pressure wound dressing has done is, it has given the environment which is the most optimal for this sort of wounds to heal, because it creates an environment which is absolutely non-conducive for any bacteria to grow. It creates a negative suction which promotes granulation, because it brings the oxygen and blood to the tissues and improve the granulation. It keeps the wound moist. So, and then the dressing stays for next 3, 4, 5 days depending on the wound.
Yeah.
So which means that it doesn't require to be changed once or twice in a day. So except for the, I would say, initial cost which comes to your mind, that probably it's an expensive proposition. But if you see the overall effect or the time benefit which we are getting and the results, I would say there were so many feet or legs which we thought that probably we will not be able to salvage them. Now we are able to salvage them with negative pressure wound dressing. And that is why I would say today, if you ask any physician or a surgeon who has had experience with this therapy, they will only have good things to talk about this therapy, because normally, you will have a mixed feeling. If there are other lot of dressings also. There are, I would say, dermal replacements. There are some other growth factor derived dressing. There are some silver based dressings. So people might have a different opinion that probably, they have worked in our setup, they have not worked in our, so they have their different bias. But negative pressure wound dressing, I don't think so anybody would have something bad to say about it. It is something which is very encouraging and really a game changer for us.
And so some special precautions of negative pressure wound therapy when applied to a diabetic foot, because there are multiple pockets out there. So what is different and specific for diabetic foot?
Definitely, I would say a good technique is very important for any sort of a therapy. And it becomes more important for negative pressure wound, because what we are doing is we are creating a negative suction, and these are ischemic feet. So when we do these dressings, we do not have to apply these dressings circumferentially. Because if they are applied circumferentially, they will create a negative suction which will work as a tourniquet. So it will further compromise the distal blood flow. So that is something which is very important. And then we have to be very, I would say, clean in applying these, in the sense that we should not cause any leakages. So it has to be secured very well. And sometimes we do have challenges, because a lot of diabetic patients, they have ulcers on the plantar surface, which is a weight-bearing surface. So if we are giving a dressing on a weight-bearing surface, then we have to counsel and educate them that probably, you can't, because something, going to a bathroom, which is something that the least they have to do on a daily basis. So then they need some sort of an assistance, because if the dressing becomes loose and it starts getting is not able to create a negative suction, then we lose the whole benefit of it. And other thing, what we tell all our patients is that in case if the dressing is leaking, then definitely they have to come immediately to get it changed.
And how do you monitor after 5 days, 3 days, 4 days of treatment, whether the wound is kind of coming?
For the first change, usually everybody prefers to do it within 2 to 3 days, so that they just want to see whether the whole process is helping them or not. So when we remove this and there is healthy granulation, the wound looks pink, the margins are not macerated, and there is a minimal slough, then we know that this therapy is working. So what we do is we make sure that we remove whatever the residual slough is, and we can reapply the wax, and then we can delay the next change. So suppose we have changed the first on say 3 days, probably next on 4 days, but I would say the maximum upper limit for us is not more than 5 days. Or else, because with the negative pressure wound dressing, people who are aware of it, who have used it, obviously if the canister which is filling the exudate, that is filling very fast, then probably these patients are either nutritionally compromised, there is a lot of lymphoria happening, so we might have to change our strategy in these patients.
And sir, looking at advancement or unmet need in negative pressure wound therapy for diabetic, do you see any unmet need or advancement, seeking some advancement in negative pressure wound therapy?
Definitely the VAC, which has a continuous fluid running into the wound, because what it does is it keeps the wound surface moist. So a lot of people have started using special antimicrobial agents with that. If the wound is significantly infected or the wound is extremely dry, because it helps to keep the wound moist also. So these, I would say, advancement. So there are certain of advancement in the serrations and the pores in the foam, which has also been done to promote further debridement. There are certain enzymatic, I would say, based preparation which work as autolytic therapy to remove the slough. So some people have to mix and match these also, but I would say that so you should keep everything on board, and from case to case we can decide that what is best for these patients. And but I would say the in the end the principle remains keeping the environment antimicrobial, keeping the blood supply good, covering them with good antibiotics, and offloading their wounds. This is something which will definitely help.
Very nice. And sir, once the wound is healed, what precautions patients should take, and what counseling you do for preventing the recurrence of the
It's
ulcer
a
and the wound?
very relevant question, because what the clinical data suggest is that 1 in 3 of healed diabetic foot ulcers will have a recurrence. Because what people they forget is that we have healed a ulcer, which is a complication of a disease. So it's very important to keep the disease under control, number one. Number two is the foot mechanics keeps on changing. Normally you would see everybody has a medial arch. Like, if you don't understand medial arch, you will understand that people suffer from flat feet. People who have flat feet, they are not fit to get recruited in any armed forces because they have a faulty weight distribution. So people who have diabetes, or unfortunately because of previously affected diabetic foot, they have landed up in some sort of an amputation. They have lost either 1 or 2 or 3 toes. So the foot mechanics changes, and when they walk, they will be putting weight on those areas which are not, I would say, supposed to be taking that sort of a weight. So they require proper customized footwear. So now you have these dedicated machines which are called mat scan. So a person puts his foot on that. The machine assesses that which are the areas which are taking most of the pressure. So a customized insole is fabricated by a 3D printer, so that when you use that insole, those pressure areas are offloaded.
Right.
Because normally nature has made our body and our neuroreceptors in such a smart way that while we are sitting, lying down, standing, we keep on shifting our weight from different areas, which becomes totally faulty with diabetic patients. So we need to offload so that they should not have a recurrence of these wounds.
Yeah. And I think I think we have spent a lot of time. Last question on this, sir. I've seen that you've started this initiative as a part of the larger cause is Amputation-free India.
Yeah.
How big is that problem? What is that passion about that Amputation-free India? Because it seems when we live in tier 2, tier 1, tier 2, it seems that it's not that common.
Yeah.
But what's your view on that?
As vascular surgeons, the surgery which we hate the most is doing an amputation, because something we are trained for is to save limbs and save lives. So we hate doing an amputation. So individually, most of the vascular surgeons, they started these campaigns individually at their level, that save an amputation and save a life. But eventually, I'm so grateful to our Vascular Society of India. They started because 1st of August is celebrated as the Vascular Day in India. And the office bearers of Vascular Society of India took this initiative that we would carry out a campaign at all vascular center across India on the same day. And it's been growing over a years. Initially, they were, say, 5 centers. The last year, they were around 40 centers. This year, they plan to do it almost around 100 centers across India. And everybody had tried to bring awareness that because, it's a major burden on society, that, people losing their limbs because it increases their morbidity. It's an added socioeconomic cost. And so we want that people should be aware of complications of diabetes. They should invest in prevention more, because if we can, we have talked so much about treating and how to diagnose and how to take care of. Always people, they always neglect is prevention. And I would say in school we were told a proverb: prevention is better than cure.
Yeah.
So it doesn't. This is a condition which stands more than true about anything else. That for diabetic patients, if they can invest in prevention, they should take care of their feet. They should have proper footwear. They should keep their sugars under control. They should have a healthy lifestyle. Stay away from all the risk factors, especially smoking, because that would affect their blood vessels significantly in their treatment.
And as you said, acknowledging that there's a problem and we have to prevent to reach to that problem. That's I think that's the purpose of this campaign.
Definitely,
right? So I think
definitely.
And so if a patient gets a diabetic foot, I think awareness about which doctor to approach. My diabetes is being managed by a physician, then I have surgeons in my vicinity. So a lot of time I've seen that kind of navigation through the healthcare services is also a challenge.
But good part is that that gap is becoming less now, because most of the diabetologists these days, they are aware of these complications. So every diabetologist, when they have a patient who suffers from diabetes, they always examine their pulses, digital pulses, and if they feel that there is some compromise of blood supply, initially having a color Doppler test, which is an ultrasound for your legs to check the blood supply, was rare, and it was not readily available. Now, fortunately, in India, you can get a color Doppler done anywhere.
Yeah.
So and most of the diabetologists in, I would say, multi-speciality hospital, they are working in tandem or in teams where they have a vascular surgeon or a diabetic foot care specialist on board, so that they don't miss on these. And so that's our message to most of the physician forums is also, because in tier 2, tier 3 cities, you don't have trained endocrinologists treating patients with diabetes. You have general physicians, or for that matter, sometimes a plain MBBS doctor. And I would say they are doing excellent job. But we do conduct a lot of CMEs to make them aware of these newer treatment modalities which are available, and how to diagnose and how to guide their patients and how to refer them at a correct point of time also for these interventions.
Yes, I think on just off the professional, how do you take stress off your mind? I mean, a busy lifestyle, busy, so many surgeries, so many patients. How do you take?
So normally the people have this faith that you take a break, spend your time with pets, go and play a sport that would de-stress you. And somehow, when we work in a hospital, we realize that probably, that's not going to work for us. So we have to indulge more in what we do the best. So for us to, I would say, a stress buster is not to go away from work, to even do more work and spend more time with patients and, give them more. So that satisfaction, when we are giving more, takes away our stress rather than running away from our work. So that's my philosophy.
Yeah, very nice, very nice. And if, in hindsight, if you were not the surgeon, then what would have been the alternative thing you had in mind as a child, as a growing child?
Probably when you're growing up as a child in school, every day, I think there would be any child in India who doesn't want to become a pilot, who doesn't want to fly a plane. But, eventually, once I became a doctor, and especially when I became a surgeon, and after almost now 25 to 30 years in practice, I don't think so I would have been doing justice to any other profession what I can do to this. So I'm very happy, and I believe that if I get a chance in my next life also, I would like to become a surgeon only.
Thank you, sir. I think
thank you for conducting this podcast, because eventually the whole purpose is to make people aware that now, first of all, try to prevent diabetic foot infections, and in case somebody develops an infection, they should not worry, because we are now, I would say, equipped as the rest of the world. We are offering best of the therapies. We can take care of any sort of infection, and we would try our level best to salvage your feet so that we can make our country an amputation-free India.
Yeah. And the idea is to trigger the conversation. As you said, trigger the conversation. that would trigger more conversations, and that's broader. The idea is to generate awareness around this topic.
Because yet to find a household in India where one of the family member is not suffering from diabetes.
Yeah.
So it's a household problem now. It's not that initially we used to feel that okay, I don't have diabetes, so probably I should not. So if you don't have, somebody in the family will have. So we have to be very careful about it.
So diabetic foot में injury कौन से part पे ज़्यादा होती है?
Usually, there are two things. If I talk about this winters, most of the patients which we had, they had caused injury because of extrinsic trauma by exposing their feet to extreme cold or extreme hot things.
Yes,
probably because they will keep their feet in front of the heater and they will not perceive any sensation. And I have been told by the family member that they didn't realize somebody else saw that the foot started burning also. So it's that, and people have had rat bites which they have not realized because there is no pain. They have been wearing shoes with some small pebble or something inside the shoe which they have not realized. And that has been continuously causing trauma to the foot.
So shoe bahar rakha, usme pebble aa gaya, and then they
don't realize it. So it's such a common thing. But definitely for diabetic patients, we normally use the term glove and stocking. So that's the area where significant peripheral neuropathy occurs, and these are the areas where they feel burning or pinpricks. So these are the precursor of the major catastrophe, because if these patients, they land up and they tell their physician, we are getting burning of feet, or we are having numbness in our fingers and we don't feel any pain in this area. So this is the subset of population which needs to be counseled very smartly, because they are prone to developing diabetic foot ulcers because they would not realize any pain. And so they have to, we tell them that, don't walk barefoot, don't expose your feet to extremes of temperature, and always examine your feet before you retire to bed. And poor blood supply in these patients lead to a lot of fungal infection in their toenails also. So it's very important to use some good antifungal lotions also for the toenails, so that we don't promote fungal growth because of poor blood supply.
And once you get an injury, the management, rush to a doctor, manage that. How do you kind of?
So usually we tell our patients that in an ulcer in a diabetic patient, the treatment has to be a little more aggressive, and wound in a younger age group heals better because tissue regeneration is better. As the age advances, as the disease advances, as they have multiple comorbidities, we have to be very aggressive. So, for a young child, if he injures himself while playing, probably he might not require any antibiotics. The wound will heal within few days. But we cannot take that risk in these immunocompromised patients who have got significant high sugars and sometimes chronic kidney disease also. So what we need to do is we need to do proper aseptic dressings. We need to use some antimicrobial agents. We need to give them some antibiotics. During that period of time, we have to be very sure that their sugars are under control. So we need to be a little more cautious in these patients.
And sir, antibiotic resistance is a big problem, and antibiotics are also cytotoxic in nature in general. So, and in diabetes, it's difficult to manage the infection because of the underlying disease. So, what challenges you see?
Thing is, like if we go into the technicality of this, then we need to understand that these diabetic foot care infections, we do have a lot of bacteria colonizing these wounds, which might not look infected like a frank infection. It's not that they look red, they have pus pouring out, something like that. So those are different sort of wounds. On the contrary, we might have some wounds which are so foul smelling, pus pouring. So what we need to do is we need to immediately send cultures so that we treat those specific organisms which are causing that infection in that particular patient. And then simultaneously we would get sensitivity test also, culture and sensitivity test for these organisms, because unless until we are specific with those antibiotics which are effective, Otherwise, we are just delaying the wound healing because we are giving them some antibiotics which are not working.
Yeah.
So that's something which is very important. And then we have to be very careful, because if these patients are renal compromised, there are certain drugs which needs to be avoided. There are certain drugs which dose has to be adjusted. So all these things are very important.
Yeah. And while I was doing my internship at Civil Hospital Ahmedabad, we used to get a lot of these patients, and that while back with maggots.
Yeah.
Wounds get so infected that gross maggots. Still, what's the do you get to see?
So it's a very interesting thing, because I'll tell you a story that during World War II, when antibiotics were less, and because the weather there was cold, and a lot of people, they had to fight in those wet trenches. So a lot of people, they injured their legs, they had gunshot wounds. So all those patients whose wounds were infected with maggots, their limbs were saved, and all the patients who had no maggots, they landed up with amputation.
Oh, interesting.
So now there is a therapy by which is in India, it has not become very popular, but in Sri Lanka and Singapore, it's there, which is called treating these diabetic foot ulcer with intentionally with maggots. Because what maggots they do is they only eat dead necrotic tissues. They don't eat healthy tissues. So they are, I would say, a living de-sloughing agents, which are living organisms which are de-sloughing. Obviously, it looks very horrifying. Somebody who sees that, there are maggots in the wounds. It looks very, I would say, disturbing. But otherwise, it is benefiting the patient. And so the bacteria, as I said, we need to remove the slough, because the bacteria will only grow on dead tissues. And maggots remove the dead tissues, so the bacteria don't get any environment to stay there. So that is why the infection doesn't happen.